Hi, my name is Kristen Parker, and today I will be discussing my proposal for the adequate intake of calcium and vitamin D among high school female athletes program. Proper nutrition is very important for the female athlete, specifically calcium and vitamin D. Calcium is important for bone growth and maintenance, while vitamin D assists with calcium homeostasis and bone metabolism. The dietary guidelines state that the RDA, or recommended dietary allowance for calcium, is 1,300 milligrams for females 14 to 18, and the RDA for vitamin D is 600 international units for the same population. Low consumption of these micronutrients is a health risk, as vitamin D insufficiency is a risk for cancer, poor immune function, low bone mineral density, and heart disease. Insufficient calcium intake can lead to osteomalacia and osteoporosis. Recent studies have shown about 61% of youth suffer from vitamin D insufficiency. Among teenage females, hormone levels are also changing at this age, and an increase in estrogen leads to an increase in calcium storage in the bones if adequate calcium is consumed. Because peak bone mass occurs during adolescence, insufficient intake of these nutrients can lead to lifelong low bone mineral density. The participants in this intervention will be athletes who demonstrate physical activity. One study by Rowland and colleagues has shown that consumption of calcium and physical activity together can increase bone mineral density, which may protect against musculoskeletal injuries, which are prevalent among high school female athletes. For this intervention, the theoretical foundation uses the health belief model and social ecological model. The health belief model is a behavior change model that explains how an individual's perceptions lead to engagement in a health-related activity. A cue to action is necessary for behavior change. Cues to action can be internal, such as physiological cues, or external, like events or recommendations from media, healthcare providers, peers, or family. The cue to action for this intervention would be the informational flyer that will be sent to all individuals on the sports coaches' rosters, as well as the coaches informing their players about the intervention. The four main perceptions of the health belief model are perceived susceptibility, perceived severity, perceived benefits, and perceived barriers. Perceived susceptibility refers to the perceived risk of developing a health problem. Adolescent girls tend to feel very powerful and may be more likely to engage in a risky behavior because they have low perceived susceptibility. The lessons will be taught by a registered dietitian, and participants will learn how prevalent vitamin D and calcium insufficiency or deficiency is among their population. Perceived severity refers to how severe the individual perceives the health problem could be and its potential consequences. The aim of Lesson 6, titled "What's the Worst That Could Happen?" is meant to teach participants about the consequences of vitamin D and calcium deficiency, especially among athletes. This will likely increase their perceived severity, making them more likely to consume vitamin D and calcium. Perceived benefits refer to the degree to which the health-promoting activity will be effective in reducing the risk of the health problem. The intervention lessons will teach participants about how calcium and vitamin D intake directly correlates to higher bone mineral density, which directly impacts their sports performance. Perceived barriers are obstacles preventing engagement in a health-related activity. Perceived barriers among this population could be peer pressure, lack of time, or low socioeconomic status. These barriers will be overcome by limiting drastic changes and occurring around sports practices and events. The social ecological model evaluates the interaction between levels of influence on one's behavior. The levels of influence include policy, community, organizational, interpersonal, and individual. A study by Scarnio and colleagues concluded that the social ecological framework can successfully be applied to the realm of sports. For this intervention, the individual would be the athlete. Factors on the individual level that could influence behavior change are age, education, and socioeconomic status. The participants will be engaged in 6 intervention lessons that will teach them many aspects of nutrition, specifically regarding calcium and vitamin D intake. Lesson 5 will teach participants how to make healthy snacks that promote calcium intake. The athletes will also be provided nutrient-dense snacks after practice and nutrient-dense meals after games, which will be free to participants and will increase intake of calcium and vitamin D. The interpersonal level refers to the close relationships an individual has that can influence their behavior, like peers, family, and coaches. On the interpersonal level, coaches and parents are encouraged to attend the intervention lessons. Parents and guardians are also invited to 6 monthly cooking lessons where they will learn how to cook nutrient-dense meals. Many parents provide meals for their children, so teaching them how to cook meals that are rich in calcium and vitamin D will likely influence the meals they are giving their children. On the organizational level, this refers to the settings where the health-promoting behaviors can occur. For our population, this would be their high school. The intervention participant lessons will occur at their school directly after practice to limit transportation as a barrier. Within the school, the food service director will receive a stipend to offer a greater choice of nutrient-dense foods at breakfast and lunch. The school nurses will also meet with a dietitian to learn about sports nutrition, specifically calcium and vitamin D. The community level of the social ecological model involves the broader context surrounding the athlete. This can refer to the physical community that they belong to, or it can mean those involved in their particular sport. Physicians in the area surrounding the school will have the same opportunity as school nurses to attend a presentation by a dietitian to learn about sports nutrition and recommendations they can give to athletes who visit them. The physicians will then be more knowledgeable about sports nutrition, specifically calcium and vitamin D, and they can use this knowledge to inform athletes about the value of these micronutrients and how to achieve adequate intake. It is expected that the high school athletes participating in the intervention will consume more calcium and vitamin D than those in the control group. An increase in 250 milligrams of calcium in the diet was shown to improve bone mineral density in a previous study. This would be hypothesized as the increase for calcium consumption, specifically among individuals who are deficient or insufficient in calcium consumption at baseline. The improvement in calcium and vitamin D consumption among those in the intervention group will be due to the education provided by the lessons, the post-practice nutrient-dense snacks, and the post-game nutrient-dense meals. It is also hypothesized that the intervention group will show higher 25-OHD vitamin D serum levels than those in the control groups. Based on a previously mentioned intervention by Houston and colleagues, intervention groups will likely have 25-OHD vitamin levels of 22.5 plus or minus 12.2 compared to the control groups with 18.9 plus or minus 10.6. This is expected to have a positive correlation with improved consumption of vitamin D. Vitamin D consumption and therefore serum levels will increase because of the education about vitamin D, the nutrient-dense post-practice snacks and post-game meals, and the increased vitamin D-rich options at school lunch and breakfast. It is expected that an average increase of 0.8 bone mineral density will be demonstrated using the DEXA scanner among participants based on previous studies compared to no change in the control group. This intervention will be a randomized control trial with a 3-group design. There will be 1 intervention group and 2 control groups. The high schools will be the unit of randomization and will be randomly allocated to the intervention or control groups. 3 Class AA high schools in New York State will be targeted, including New Rochelle High School, Rockland High School, and Arlington High School. Each school district will receive a $1,000 stipend upon completion of the study. The necessary sample size is 2 for this study's results to lead to a significant increase in intake of calcium and vitamin D. Sample size was calculated using an online generator, but an ideal sample size would be larger to increase reliability and validity. For these, the inputs were mu1 as 43, mu2 as 97, and sigma was 11.5. Class AA schools have approximately 1,000 students or more. Estimation of the actual sample size will be approximately 150 students between the 3 schools. Participants will be female athletes in at least one sport at their high school. Exclusion criteria includes pre-existing health conditions that affect dietary intake, and participants also must be female, ages 14 to 18, and play at least one sport at their high school. To recruit participants, the coaches of each women's sports team will be asked for a roster of all current players with emails and will be asked to inform their players about the intervention. Informational flyers and consent and assent forms will be sent to each student on the roster by a recruiter. One incentive for participation will include a day trip to Atlantic City, New Jersey for all participants upon completion. This will allow participants to bask in the sun to increase vitamin D, and 2 nutritious meals will be provided. Participants of the intervention will be involved in monthly lessons focused on nutrition, specifically calcium and vitamin D. These lessons will be taught directly after practice, and parents and coaches are encouraged to attend. The lessons will be taught by a dietitian and will each feature a hands-on activity to engage participants. The lesson curriculum summary will be provided to students as a brochure to take home and keep even after the intervention has been completed. The athletes will attend a 1-hour presentation by Olivia Dunn, who is a gymnast at Louisiana State University and famous TikTok star. This presentation will be open to the athletes' parents, coaches, and community. The discussion will be regarding Olivia Dunn's journey as a college athlete. She will discuss nutrition, the tax that athletics has on an athlete's body, and her experience as a woman in athletics. Participants will be able to ask questions. Athletes will also be given nutritious snacks, which are rich in calcium and D, after every practice. And the athletes will also be given a post-game meal for after games, which will be designed based on the USDA MyPlate, ensuring each food group is included. These will be prepared by a chef with the help of a program assistant. The school participating in the intervention group will offer more choices at breakfast and lunch that include calcium and vitamin D. The dietitian will meet with the food service director of the school to increase the micronutrients in the meal. The food service director will receive a $1,000 stipend that can help to make these changes to the menu. There will also be cooking classes for parents or guardians of participants led by a dietitian and a chef. These cooking classes will be held monthly, and each class will feature one healthy, nutrient-dense entree. The recipes will be sourced from the MyPlate Get More Calcium recipe collection. The classes will feature a diverse selection of meals to appeal to participant preference. Teaching parents how to cook these meals will allow them to incorporate these meals into their daughters' diets. School nurses and local physicians will have an opportunity to attend a presentation by a dietitian to discuss the importance of calcium and vitamin D intake in adolescent female athletes. The lessons will include signs and symptoms of low calcium and vitamin D levels, as well as foods that professionals can recommend to their patients. There will also be social media outreach. A TikTok page and Instagram page will be made posting nutrition tips, recipes, and news about female athletes. All recipes from the practice snacks, post-game meals, and parent-guardian cooking classes will be available on both social media platforms. Posts will also be made at least 3 times a week by the program assistant. All evaluation measures will be the same for intervention and control groups. Pre-test evaluation methods include an individual 15-minute meeting with a nurse and 15-minute meeting with a dietitian for all participants. The primary outcomes for this intervention will be calcium and vitamin D consumption increased in the intervention group. The secondary outcomes would be increased vitamin D serum levels and increased bone mineral density. The primary outcomes of this intervention, improved calcium and vitamin D consumption, will be evaluated using a 3-day food record administered by a dietitian. A study by Mailhot and colleagues showed successful use of food records for estimating calcium intake. The secondary outcome of the intervention increased vitamin D serum